So I'm gonna start today my presentation on the venous side. It's gonna be pelvic congestion syndrome. So what is pelvic congestion syndrome? So pelvic congestion syndrome, also called pelvic venous insufficiency, is a chronic pain condition associated with blood flow problems in your pelvic veins. So chronic means more than 6 months. The patient would present with more than 6 months pain to their pelvic region. So the pelvic pain associated with PCS, which I'm going to refer to, often involves weakening vein walls in your ovaries and pelvis. The veins dilate within and might become twisted and overfilled with blood. As a result, blood might pull into the pelvis, causing patient to feel a lot of pain. So according to the Cleveland Clinic, 40% of the GYN visits are related to that. And according to the Whitley Clinic, 1 in 3 women are misdiagnosed. So why is it so important to be familiar with possible symptoms of PCS and to rule out when it's on your differential diagnosis? So as I mentioned, 40% are GYN, and 30% of these are likely related to pelvic congestion syndrome. So 1 in 3 women with chronic pelvic pain are misdiagnosed, and they don't receive treatment. So the cardinal symptoms of PCS, right? So it's a pelvic pain with a dual throbbing positional nature and tenderness to the deep palpation. So women with will also frequently complain of dyspareunia, which is pain during intercourse, postcoital pain, dysmenorrhea, like menstrual cramps, and pelvic pain and heaviness with prolonged standing. So, and they might be worse at the end of the day, right during the period, and standing for too long or sitting down for too long. Other symptoms also included, right, you're gonna be seeing when you see the patient are this varicose vein to the thigh, to the butt. You wanted to make sure you have that diagnosis as second, like as your differential diagnosis. So you wanted to make sure you rule out, you're never gonna, forget about it. So another thing is like a dysmenorrhea, which is pain during peeing. And if you think about even diarrhea and constipation, so sometimes we see patients in the primary care that they present with the symptoms, right? And and it's one diagnosis that a lot of clinicians might not be aware of, like primary care. And the risk factors, pregnancy, especially after many pregnancy, and hormonal estrogen is another thing. So childbearing women. All right, next. Diagnose, so ultrasound, MRI, CT scan, but the gold standard is venogram. So treatment, hormonal medication include the metroxyprogesterone acetate and goserelin. I don't know if I'm pronouncing it right, but those are less invasive. But as we do in our clinic, right, the embolization, embolization with the coils, or what we're aiming for the patients that are suffering for too long with that condition.
Let me just chime in here. So the medication does not work. I've been treating this for a while. It doesn't work. So hormonal medication does not work for this. Putting someone on hormonal medication is actually not the best thing for this problem as well, because there's side effects on therapy. So definite therapy is the best therapy for this condition.
Yeah. So the guidelines, they want you to start less invasive, but the procedure, it's what you're gonna see a very significant improvement. All right, so a quick case. This is a unique case of PCS in an active female runner. So I'm gonna go quick. So a 39-year-old woman gravid at 4, part of 4, which meaning that she was pregnant 4 times, she delivered 4 times. So presented with 15 years history of left hip pain and several months of low back and leg pain. Previously, very active with running, cycling. The patient exercise tolerance had declined over time because of hip pain to the point that she was no longer able to exercise consistently. In addition to her primary complaint of hip pain, she had a radiating paresthesia, which is numbness from the left lower back to the left lower extremity over the preceding several months. She denied any mechanical symptoms of the left hip and did not experience episodes of urinary retention or bowel incontinence. There was no history of trauma. She experienced only minimal symptoms of relief with chronic non-steroid like NSAIDs and physical therapy. This was a case from the Medical Journal of National Institute of Health. So they had 2 and I chose just to present 1. So this is too long, but I'm gonna go just tell you really quick. So they did some clinical assessment. They noticed, that she had some symptoms that would lead to maybe sciatic origin. And so she had an MRI done, which showed that she had no issue with her discs. Everything was with her normal limits, but they did found that she had a PCS, right? From that, they did a venogram, demonstrating a marked left gonadal vein reflux. So the right gonadal vein was intact with a complete valve. So the right one was fine. So the issue was in the left, which is 80% of the cases in the left. And they treated. So after they treating 3 months follow-up appointment, she experienced significant, she didn't have much improvement, but in the 6 months mark, a post-embolization, she had a significant improvement in her symptoms. She went back to, being active, running and cycling as, a 39-year-old should be. So it's very imperative for us clinicians to be aware of, okay, it's a new woman, she's 39. This doesn't happen just when you're 40, 50, we need to have that, in the back of the mind. So outlook and prognosis. So pelvic congestion syndrome is not a life-threatening. Depending on the severity of the pain, it can disrupt the patient quality of life, right? So as we see in this case study. So although there isn't a standard treatment, but that pelvic congestion syndrome, the outcomes associated with the intervention to provide a pain relief are excellent, which is what we do in our clinic. So the literature states that 75% of the people who receive ovarian vein embolization experience pain relief. Recurrence happen only 5% of the case. So it's a treatment that really works, right? Minimally invasive. We get happy women out there being treated, and I'm just amazed for what we do in our clinic, helping women. So to conclude, as I said, imperative to increase patient and collaborative team members' knowledge about PCS, meaning everybody, all the clinicians. As I mentioned, a lot of primary care, they're not aware of this condition. So by doing so, patient and clinician will work together to successful case outcome. Clinician will have a PCS in their differential diagnostic list, therefore helping to decrease misdiagnosed patient with PCOS and improve patient outcome.